Trisakti, tempat kita berjuang menggapai mimpi, jatuh bangun tetap berdiri kembali, kan ku kejar mimpi ini. Sivitas FK, Trisakti tercinta, sahabat keluarga dan rumah kita, ciptakan karya dalam sinergi, bersama taklukkan hari. Kadang lelah ingin menyerah, sejenak istirahat tak mengapa, kemudian lalui, jangan berhenti. Dalam doa pastikan terlewati. Selamat datang di FK Trisakti, tempat kita berjuang menggapai mimpi, jatuh bangun tetap berdiri kembali, gapai mimpi mulia ini. Semua perjuangan untuk masa depan bersama FK Trisakti.
Halo rekan sejawat, berikut adalah cara akses sertifikat pada webinar ini. Klik pada button Get Hostess pada akhir acara. Silakan isi post-test yang tersedia. Jika sudah selesai, silakan klik pada button Submit. Jika lolos, silakan klik button Get Certificate serta masukkan nama dan gelar. Bila sertifikat belum siap untuk didistribusikan, silakan cek secara berkala pada button Certificate di bawah video webinar. Terima kasih.
Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi kami ucapkan. Yang terhormat Dekan Fakultas Kedokteran Universitas Trisakti, Dr. Raditya Ratsangka, Spesialis Obstetrik Ginekologi, Subspesialis Obstinsos. Yang kami hormati Wakil Dekan 1 Bidang Akademik, Dr. Yeni, Spesialis Farmakologi Klinik. Yang kami hormati Wakil Dekan 2 Bidang Administrasi Umum dan Keuangan, Dr. Purnamawati Chin, Magister Pendidikan Kedokteran. Yang kami hormati Wakil Dekan 3 Bidang Kemahasiswaan, Dr. Tubagus Ferdi Fadilah, Spesialis Anak, Magister Kesehatan. Yang kami hormati Wakil Dekan 4 Bidang Pengembangan dan Kerjasama, Dr. Rita Hairani, Spesialis Paru, Magister Kesehatan. Yang terhormat para guru besar dan Bapak Ibu dosen Fakultas Kedokteran Universitas Trisakti, serta para hadirin dari dalam maupun luar negeri. Puji dan syukur marilah kita panjatkan kehadiran Tuhan Yang Maha Esa, yang telah memberikan limpahan rahmat sehingga kita dapat hadir pada kesempatan hari ini dalam kondisi sehat walafiat. Saya, Karina, yang akan memandu acara pada pagi hari ini. Selamat datang pada acara mini simposium yang merupakan program dari Continuing Medical Education Fakultas Kedokteran Universitas Trisakti. Baik Bapak Ibu peserta mini simposium, saya akan membacakan susunan acara sebagai berikut. Kata sambutan oleh Dekan Fakultas Kedokteran Universitas Trisakti, Dr. Raditya Ratsangka, Spesialis Obstetrik Ginekologi, Subspesialis Obstinsos. Yang kedua akan dilanjutkan pemberian materi oleh pembicara, Prof. Tunku Kamarul Zaman bin Tunku Zainal Abidin MD MS Ortho PhD FASC dengan judul materi The Importance of Biomechanical Environment in Musculoskeletal Homeostasis and Regeneration. Pemberian materi kedua oleh Dr. Erika Collins, spesialis ortopedi consultant PhD dengan judul materi The Role of Biologic Method in Enhancing Rotator Cuff Repair. Dan dilanjutkan dengan sesi tanya jawab. Selanjutnya saya akan membacakan pesan peserta webinar. Kepada peserta webinar, silahkan menuliskan pertanyaan pada kolom komentar di bawah. Terdapat saldo OVO dan GoPay untuk 2 penanya terbaik. Bagi penanya, harap konfirmasi melalui email D2D yaitu info@d2d.co.id. Jika tidak ada konfirmasi selama 2 minggu, maka hadiah akan hangus. Ikuti webinar sampai selesai dan jangan lupa untuk isi post test pada tombol Get Post Test di bawah video webinar untuk mendapatkan sertifikat. Silahkan cek secara berkala tombol sertifikat yang sudah tersedia. Mengisi link survei dengan cara klik link pada description box di bawah ini. Untuk informasi webinar dan update fitur dan ilmu kedokteran lainnya, silakan follow Instagram D2D yaitu @d2d.id. Selanjutnya akan ada pemaparan etik dan passion. Oke. Etik dan patient safety yang kami akan bacakan pertama yaitu Etika MKEK ID Pusat Wilayah dan beberapa cabang Dewan Etik Perhimpunan Dokter Spesialis, Kemahkaman Pengawasan Pembinaan Pembuatan Fatwa Etika Kedokteran di tingkat pusat, Majelis Kehormatan Etika Rumah Sakit Indonesia atau Makersi, terutama mengatur etika RS dan pimpinannya serta relasi antar nakes dalam RS. Komite Etika dan Hukum serta Subkomite Etik, Komite Medik di Rumah Sakit. Disiplin MK DKI di bawah KKI Kewenangan Kemahkamaan dan Pembinaan. Hukum, legalisasi hukum DPR dan pemerintah yang diatur dalam undang-undang, pemerintah hukum di bawah undang-undang, proses penegakan hukum, Kepolisian RI, jaksa, pengadilan, dan aparat hukum lain sesuai kewenangan. Nilai-nilai keutamaan yang perlu diperhatikan, kepemimpinan yang jelas atau DPJP, kriteria medis dan otonomi pasien, mengutamakan kepentingan pasien, menghormati keputusan pasien dan keluarganya secara otonomi, etika kesejawatan, musyawarah antar sejawat untuk mendefinisikan prioritas kepentingan pasien yang lentur dan sesuai dinamika dan melibatkan pasien dan keluarga. Memperhatikan dinamika klinis dan sosial pasien dapat merubah skala prioritas dan dapat merubah keputusan bersama-sama. Standar keselamatan pasien, setiap rumah sakit wajib menerapkan standar keselamatan pasien yang meliputi hak pasien, mendidik pasien dan keluarga, keselamatan pasien dalam kesinambungan pelayanan, penggunaan metode peningkatan kinerja untuk melakukan evaluasi dan program peningkatan keselamatan pasien, peran kepemimpinan dalam meningkatkan keselamatan pasien, mendidik staf tentang keselamatan pasien dan komunikasi merupakan kunci bagi staf untuk mencapai keselamatan pasien. 6 sasaran keselamatan pasien. Sasaran pertama, ketepatan identifikasi pasien. Sasaran kedua, peningkatan komunikasi yang efektif. Sasaran ketiga, peningkatan keamanan obat yang perlu diwaspadai. Sasaran keempat, kepastian tepat lokasi, tepat prosedur, dan tepat pasien operasi. Sasaran kelima, pengurangan risiko infeksi terkait pelayanan kesehatan. Sasaran keenam, pengurangan risiko pasien jatuh. Baiklah, para hadirin mini simposium yang berbahagia pada pagi hari ini, kita akan memulai acara ini dengan kata sambutan dari yang terhormat Dekan Fakultas Kedokteran Universitas Dr. Raditya Ratsangka, Spesialis Obstetrik Ginekologi, Subspesialis Obginsos. Kami persilahkan.
Terima kasih, Dr. Karina. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. Welcome and thank you to all participants for joining this webinar this morning. And thank you also to Professor Tunku Kamaruzzaman bin Tunku Zainal Abidin and Dr. Erika Holin, who have been willing to be speakers at this morning webinar. I would like to express my appreciation to the committee for choosing the topic, the role of biologic approach in orthopedic surgery, as the topic of our webinar this morning. The biologic approach in orthopedic surgery represents a shift in the fields toward treatments that focus on enhancing the body natural healing process. It is gaining prominence due to its potential to improve patients' outcomes and reduce the need for more invasive surgical interventions. The biological approach in orthopedic surgery represents a paradigm shift towards the more natural and minimally invasive treatments that aim to restore and enhance the body's own healing mechanism. And while it has shown great promise in improving patient outcomes, it's essential to carefully assess each patient's condition and select the most appropriate treatment approach based on their specific needs and circumstances. So there are some key aspects of the role of the biologic approach in orthopedic surgery, which may be discussed later by the speakers. Hopefully, the material and discussion of our webinar this morning will further open our medical horizons and provide benefits also for our practice as medical practitioners. Thank you to Dr. Nani Hairunisa and the entire CME team who have prepared this webinar well. And once again, thank you, Professor Tunku Kamaruzzaman and Dr. Erika Holin as our distinguished speakers today. Have a nice webinar. Thank you.
Terima kasih kepada Dr. Raditya Ratsangka, Spesialis Obstetrik Ginekologi, Subspesialis Obginsos. Selanjutnya kita akan masuk ke dalam acara inti kita, yaitu pemaparan materi yang pertama oleh Prof. Tunku Kamarul. Sebelumnya izinkan saya untuk membacakan CV beliau. Prof. Tunku Kamaruzzaman bin Tunku Zainal Abidin, MD, MS Ortho, PhD, FASC, riwayat pendidikan PhD in Surgery and Cancer Study, University of Liverpool, United Kingdom, MS Ortho, University of Malaya, Malaysia, Diploma Science in Tissue Banking, National University of Singapore, MD, National University of Malaysia. Berikutnya kepada Prof. Tunku Kamarul, kami persilahkan untuk pemaparan materinya.
Terima kasih pengurusi majlis. Assalamualaikum warahmatullahi wabarakatuh and a very good morning to everyone. Pertama kali saya nak ucapkan tahniah dan terima kasih kepada pihak penganjur terutamanya Universiti Trisakti dan namanya adalah Dr. Nani yang jemput saya untuk pagi ini, dan saya harap sahabat kalian semua akan mendapat sedikit pandangan daripada apa yang saya akan beri pencerahan daripada di biomechanical aspect in musculoskeletal hemostasis. Saya sekali lagi nak mengucapkan terima kasih dan saya membawa kabar yang baik daripada Malaysia, Kuala Lumpur di pagi ini. So, saya harap saya punya lecture seterusnya saya akan berbahasa dalam bahasa Inggeris. Kalau tidak, saya rasa 45 minit sejak 1 jam ini tak mencukupi kalau saya berbahasa Indonesia atau berbahasa Malaysia. So, saya akan mulakan saya punya lecture pagi ini. So the topic of my discussion will be on the importance of biomechanical environment in musculoskeletal homeostasis and regeneration. Now, in many aspects, to what extent, biomechanical environment and musculoskeletal homeostasis plays an important role in the intervention of musculoskeletal therapy and orthopedics treatment per whole. While we do talk about biomechanical importance, the underplay that underlines the habit of cell has never really been put into highlight. It's because only recent years that orthopedics has gone towards the cellular molecular level to understand what happens in our clinical practice. So if you talk about mechanical loading, it's actually a very integral part in our
recording in progress.
And if you understand that during normal walking and running and our daily work, each and every part of the human body is subjected to mechanical loading in one form or the other. And if you understand that in basic engineering principles having to be adopted into clinical applications, you will note that the stress that undergoes in your body actually exceeds certain load beyond that of our own normal body load of gravitational pull. For example, if you were to climb stairs, you can expect your knees to undergo 3 times up to 4 times to the body weight, depending on the inclination of your steps. Furthermore, if you were to go and exert yourself into high running speeds and long durations, for example, marathon, the effects are simply astronomical if you have a high impact loading towards your knee. And this differs between, say, a sprinter than somebody who does long-term marathon running, where the effects are prolonged with a bit of moderate sort of force, and you have somebody who has high amount of force but very high impact. Therefore, time intensity is also a matter of contention. And if you understand this sort of mechanical stimuli, this then translate into what you can see here. I'm not sure if you can see my slide here. Is that my arrow here? Sorry, let me just try this again. If you can see my arrow here, it translates from a whole load of external loads into what you can see here into the cellular level. From the loads to the body, down to the foot, down to the joint, and down to the cartilage of the tissue itself, and right down to the cellular level, which is the chondrocytes. Now, needless to say that there are common types of loading that you see, and especially in orthopedics, loading is a necessity. After all, the musculoskeletal system in our body is intended for one purpose, mainly essentially for locomotion. And if you don't have mechanical loading, especially in the muscle, then you forget about having to move anywhere. You might as well be stiff and dead on a couch, you see. But we are designed to move, and therefore, and having to do that, when we move, we exert ourselves, as you can see the picture below, is that we go into multiple mechanical loading, either by tensional, compression, and shear force. Now, having said that, mechanical loading is not strictly limited towards just the musculoskeletal system. The rest of the body, talking about lungs, health, intestine, all of them requires mechanical loading in a good sense. For example, if one of the biggest studies that looked around to musculoskeletal system, the importance of how you have internal sort of tension causing a circular sort of motion or tension within the vessel wall provides an important homeostasis towards the balance of the formation of endothelial tissue. And not only that, a good balance of it can result in either the production of nitrous oxide. Most of you would understand that one of the conditions that you end up with atherosclerosis plaque and disturbance of the endothelial tissue is when these sort of mechanical forces alter in a state by which high blood pressure, for instance, prolonged high blood pressure, results in the formation of the reduced production of nitrous oxide, leading to those damaged vessels. So intensely, you need to discuss why not this such a common thing that occurs in our body throughout the whole system is not being looked into or upon as the main issue towards musculoskeletal diseases. Right. And I think I'll just say for one that one of the most dramatic effect in mechanical learning, especially muscle, and in fact in one of the biggest issues in space travel is actually the not just musculoskeletal but the cardiovascular as well. And you have people like these astronauts who need to undergo rigorous training while in space in order to maintain their muscle bulk, bone structures and all that. And as you can see, one of the pictures here, as a person who's gone to travel, say, these were the old pictures, the old days of the space station, the Russian space station before the ISS came into play, is where once you stay there in prolonged periods, when you come down to Earth, you don't have enough muscle even to stand up in Earth gravity. So you can understand why mechanical loading is an important aspect in our body. Right? And again, these are well documented. In fact, if you spend 30 days in space, you end up with an osteoporotic vertebrae, and that's the reason why it's important to load. And while over here on Earth, people like us, we refuse to go and even exercise for 30 minutes a day. Astronauts are expected to undergo a minimum of 3 hours of rigorous exercise per day in order to ensure that their cardiovascular as well as the musculoskeletal remain intact. Okay, and you must understand that this is a well-known side effect of prolonged weightlessness, okay, and the issues that come into play. Now, what does it mean to our orthopedic surgeons? Well, you know very well that if you let your patients off loading, for example, if you put them in a cast for a very prolonged period of time or put them on a wheelchair, you will end up with a disuse or underuse of tissue. Sometimes an overuse can occur, but and result in degeneration. But an underuse also has an important role to play, and all of this needs to be dependent upon mechanical signaling. Right. So I won't go into saying things that you not only know for now. And in many of these things, the mechanical loading, again, is important for long-term maintenance. And you must remember, if you use too much, it becomes degenerated easily. If you don't use it, you get disuse atrophy. So you need to find that small balance. And this nice picture I like over here, trying to depict an image where you find that yin and yang, or the balance between the two, is rather important. Now, just for most audience who do not know, a person who has a hip fracture and bedridden, the mortality rate for most of these patients have been recorded up to 70%, all right, within 1 year. Therefore, if you have an old lady who usually falls and have a hip fracture, just like my mother last year, and you don't get her fixed and you don't get her ambulating and the muscles actually loose, you actually end up with 70% mortality. All right, there's a chance of mortality that goes very, very high. And I would really look at it as a big problem. And while most people would see orthopedics as just being something of a problem of the musculoskeletal per se, that leads to other outcomes, and mortality is a very real outcome that needs to be considered, okay, for something that most people see it as trivial. So when tissues are subjected to insufficient excessive loading, that sort of mechanical loading do not get to pass to the next stage. Now, I need to let you have a look towards this. And one example would be a unloaded tendon, okay? An unloaded tendon results in reactive tendinopathy and tendon disrepair, okay? And if you lose it too much, at that time, you end up with degenerative tendinopathy. In one of my PhD's projects that I've looked into is the degenerative changes in rotator cuff. And while most orthopedic surgeons try to repair those things, it's important to understand why, in the first place, degenerative tendon of the rotator cuff actually occurs. And in many cases, in my numbers of series and published results, demonstrated that in most patients, very rarely that the people actually undergo stresses to allow building of those rotator cuff tendons. And over time, because they've actually lost or undergo atrophy, a sudden movement for whatever reason, because you lift up a bag or even a very trivial sort of injury, can result in a tear and sometimes massively result in the outcome. One of the things that needs to be understood is that without mechanical loading, the cells have a sense of a lack of mechanical impulse. And this translates to something called anoskia, which is a feeling of homelessness, means the cells do not attach themselves to anywhere very well. And when you subject them to some sort of mechanical loading, they activate the caspase activation pathway, which then leads to cell apoptosis. Sorry, a bit of a twisted word there. All right. And we need to understand as clinicians and scientists that perhaps mechanical loading would be the way forward, not just in a subject of clinical applications, which we already do for the past 100 years, but rather to understand how mechanical loading works. And if we were able to understand how this works at the very cellular or molecular level, we can then just manipulate it as such that we were able to go and benefit our patients in the long term. All right. So one of the areas that you may be of interest is looking at stem cells. And I won't dwell too much on stem cells because my lecture here today is not on stem cells, but rather on how over the years I've actually looked into having to manipulate the stem cells to behave the way that we have. And another one of the studies that we look at is mechanistic stimuli on the topographic surfaces, and to allow the cells to behave in such a way that we can then generate a sort of cellular response. And the techniques for mechanical stimulation can be in many ways. And the biophysical stimuli explained by cells is not just by the stretching effect by itself, but rather for the cells who have fibroblastic behavior, which is attached towards the surface. Now, for many clinicians out there, fibroblast is just a terminology of saying that it is a cell coming for a musculoskeletal sort of environment. And all fibroblasts have a certain behavior and a certain sort of characteristics, one of which is that they are stretched, they look stellate, or they can look into spindle shape. But whatever it is, they need to be attached towards the surface. Again, if it's not attached, then they have a sense of homelessness or anoskia. And because they are attached, you can literally manipulate them through the matrix of which they attach. And here you can see on the right that if you were able to elicit matrix deformation, elicit elasticity, elicit topographical changes, as you can see here, either by nanostructuring, you literally can regulate the cell behavior in many ways, and not just to its usual very gross sort of effect. And I think a person like Erica and a lot of orthopedic surgeons out there understand about the stretching, what you talk about uniaxial, biaxial stretching. And that's basically what you do in the physiotherapy sort of environment. And as I mentioned before, one of the things that I've done recently and many of our studies, I've looked into the regulation of stem cell behavior themselves. So what my next slides I'm going to do is I'm going to try to explain this concept of how mechanical stimuli is then transmitted from your gross environment, maybe due to gravity, walking, climbing upstairs, to that results in how your tissue behave or your tissue performs. As you can see, if you go up to the gym and start lifting up muscles, you end up with a hypertrophic change and you end up with this big muscular figure. So those are also mechanical impulse to a certain extent. And this concept is known as mechanotransduction, a process by which cells perceive mechanical signaling. It takes this mechanical signaling, it changes this mechanical signaling into what is known as a cellular response. And this cellular response may be a number of outcomes, and it can result in either improve in protein expression, gene expression, even it brings into signaling of cell-to-cell signaling, as you can see in this picture here, cell-to-cell to intercentral junction, or even towards local cells through cell-to-cell signaling via cytokine interactions. these have a number of cell function outcomes. As you can see, a cell signaling can even make sure that your cells survive, multiply, proliferate, and do very well, especially in stem cell differentiation. But then it also can result in apoptosis and cellular death. And this is something that's worthwhile investigating by scientists to assist in the clinical outcome in many patients. So if you need to understand how mechanical impulse, you first must understand the concept of engineering. And one of the concepts that I've come across in many years is the idea of concept by Fuller in 1960s paper in 1960 talks about tensegrity. Now, tensegrity is a very lookalike concept where you need to have an ultrastructure holding out in something that's fluidic. Now, in your cells, you must understand that your cells are literally just made of 90-95% water. The rest, they have a bit of protein, but it's all contained within a bilayer phospholipid layer, which then contains all the fluid. Now, what's holding the cells up is actually its microfilaments and its cytoskeleton, as you can see here. And if you think about it like some sort of tent, that's basically what a cell looks like, okay? It has anchor points in multiple sites, and the content of the fluid within that anchor sites gives the cells its shape. And that's why if you see under a microscope, you see fibroblastic changes and all that. It's because they have multiple anchor points. So a spindle shell site will probably have 1 point here and 1 point there, and it has this long arc shape here. But of course, you can see there's also a Philodopia like outcome, and you can see that the attach is on all these anchoring sites, which is actually a point of what we call as MAC SAM, surface adhesion molecules. And the most common of the SAM is actually integrin, which I will cover in my later part of the lecture. So these sort of structures are very strong. And the good thing about the cell engineering structure is that it's like bridge. So if you look at the bridge, you need to have this kind of structure to hold on to the lower structure. And without this sort of overarching tensegrity concept, this bridge will collapse. And if you notice that the bridge requires this sort of thing is to hold the thing from collapsing. And if you collapse this, the cell will die. And if you see in this image that I've tried to go and show is that if you were able to change this thing, so the tensile forces within the cell now changes, allowing it to now perceive a different signaling. So just like the bridge, where you put different loads, and this side can do signal loading, and you find that a lot of bridges today, the modern ones, have sensors that detect how much load they can have, especially the smaller ones. It then detects and tell you that they can only allow to a certain amount of capacity, but the cells themselves have what you call as biological sensing. And that sort of sensing is what you see of the outcome that you see following the mechanical stimuli in cells. So what happens is those signaling now gets transformed. In example of mechanotransduction, many things actually in your body get sensed, either in proprioception, touch, balance, or hearing. But more importantly for us in the musculoskeletal research, you'll talk about the pathway that activates because of the sensing from its receptors. Now, I'm not going to cover receptors because I did a whole series of lectures on receptors. But one of the more common ones is actually called SAV, which stretch activated voltage gated channels, okay, SAV. And this SAV has a downstream effects with multiple outcome. And some of the things that you can see in the outcome for the scientists over here, it is worthwhile for you to understand that calcium signaling plays an important role in this when you stretch the surface receptors. And the other one that you want to understand is something called ship, as in kapal, prahu, kapal, ship. And that stands for SRC homology 2, containing inositol phosphate kinase pathway. Now, why is it important? Because in many of our cellular transduction molecule stories, we always talk about 3 pathways that's very important, okay? And one of the things that I think scientists who are interested in looking at the metabolic downstream pathway activation is to talk about the MAPK, which is the ERK pathways, which then activate proliferation, which is rather important. Calcium important is actually for the signaling molecules. And next one, you talk about NF-kappa beta, okay, which also upstream is the activation of TGF-beta pathways. So these are some of the things that you understand. But in studies, for most scientists can relate to, ERK or mitogen activated pathway protein kinase, MAPK, also activate cell proliferation to a certain extent in cancer cells. And therefore, if you understand this concept, you can also understand that mechanical signaling is important towards the development of tumorigenesis, so which I will not cover in this lecture, and perhaps in another time we can talk about how mechanical influences reduce the signaling in tumorigenesis. Okay, but in this case, what I'm trying to say in this very simple but accurate slide is that SHIP, okay, which is the SRC homologue 2, is an important pathway that activates downstream MAPK, calcium, as well as NF-kappa beta pathways, right? So cellular mechanism transduction, as you can see, is the change in this, okay? And I mentioned before, it has not only effect towards the outcome of all these cells in terms of aging, cancer, and especially in this lecture, is talking about osteoarthritis and muscular dystrophy. But rather, I want to focus here in my slide to talk about what holds the cell together. In that concept of cellular tensegrity, you need to have something that anchors, anchors down the tent. And that's actually talking about these surface adhesion molecules. Now, surface adhesion, the most common is called integrin. Okay, and integrin is this molecule of alpha and beta proteins. Okay, 2 alpha, 1 beta. And one alpha protein they have got 15 different combination, alpha 1 to alpha 15, and beta, I think, is up to 8. So a combination of them results in addition to certain surfaces proteins. And for example, alpha 5 beta 3 is very specific towards fibromectin sort of surfaces. They are then attached towards the microtubules and microfilaments, namely microfilaments, that helps to provide that kind of tension. Okay, so what happens in a signaling pathway activation is as such that when this ECM or extracellular matrix, like the outside surface of topographical material, then stretches, these then changes its conformation. Sorry, this integrin changes conformation, then activates something called focal adhesion kinases. All right, this focal adhesion kinases then activate the downstream pathway that then, I said just now about SHIP, SHIP, then activates a whole range of activation molecules. And one of it, as I mentioned just now, is the ERK and APK pathways. And this is something very, very interesting, because now, if you imagine having to manipulate cellular behavior, you may not even need to now manipulate the cells at the level of the mechanical structure itself. You can even intervene at this level. And this is one of the interests in scientific research, is that what if you have a patient who is bedbound because he has multiple fractures and cannot move anywhere? You expect the muscle to be disused atrophy. But imagine now that you can now change the outcome by injecting something that then stimulate this pathway to result in the outcome of normal muscle bulk. That would be amazing. Now, imagine now that you can do that for osteoporosis patients, that you have a mother or father or a lot of time spending their time in bed, not exposed to suns with lack of vitamin D. You can now manipulate through pharmacological outcome, or better still, we can now manipulate the cells to then activate towards genetic manipulation. You won't worry to have to see your parents now having to undergo osteoporosis or trivial fractures anymore. So imagine the kind of outcome that you can research based on just very basic sort of principles here. So mechanotransduction for me has a huge potential for many years to come if you really understand the pathways in all of this. Right? And here, I'm not going to go and bore you with the whole detail. And integrin is this receptor of this alpha and beta sort of combination of protein, and this then forms into a cluster called focal adhesion complex. And this focal adhesion forces then downstream activate the focal adhesion kinase, which is one of the main activation of the kinase that results in the downstream effect. I won't bore you in detail for this lecture, but do understand that there's a signaling called outside-in signaling in this case, that you change the outside environment for mechanical signaling that results in cellular sort of translation or transformation, as what you will know as a mechanotransduction process. Okay, so this again, just a reminder to everybody. A mechanical signaling is not just mechanical. It can cause you to survive, the cell proliferation and cell mobility. But please understand that this receptor can also result in cell survival and cell death. And either way, it is the control or regulation of this mechanical signaling that results in the outcome that you see as a whole organism survives. All right. So there are many papers that talks about it, and they talk about how it activates. Of course, the main common, as I mentioned before, will be the ERK pathways, the calcium pathways. But the other one that you may want to read through and you come across will be the ROCK-RO pathways, which is a very interesting. And another one is if anybody comes talk about mTOR pathway, which literally takes about PI3K or phosphatidylinositol 3 kinase pathway that has a downstream effect to the mTOR, then results in the outcome for what you've seen. So these are some of the pathways that over the years have been investigated with the idea of resulting in this repair outcomes. Okay. So in my lab, okay, I'm going to talk more about my research. We've actually looked into stem cell fate by mechanical stimuli, and a number of papers we already published talks about how we manipulated this in order for us to have the desired effects, right? So let's look at the research applications. Now, I started out with my student, and this is one of my students now doing a senior postdoctoral position. They talk about the cyclic loading of cells, and you can see once you strain the cells to a certain level, and you can see that they change their sort of outcomes. And this is a AFM image, and you can see that the height and cellular changes dramatically, resulting in a different sort of protein sort of expression or deposition, denoting that there is a need for us to can regulate this at the cellular level. Okay, on this was how I started work. This was published a long time ago, back in 2010, right after I finished my PhD. And this crude-looking machine, what I built with the engineering department, was to look at what happens to this sort of fibroblast sort of change. And interesting to note, right, mechanical signaling provides a huge amount of change in terms of how cells behave. A very simple way to look into this, right? If you were to pull the cells in the direction of loading, the cells change its shape and directions very, very, very accurately, and usually perpendicular towards the direction of pull. That alone then leads to the results that you've seen in Dr. Nam's study that showed that, well, with the change of their conformation towards the direction of loading, they also change towards the deposition of the protein. So it's very interesting that this results in whether or not your tendons can survive a strong sort of loading, or it cannot survive due to underloading or changes or aberrant changes towards the mechanical loading it perceives. Okay. So what we've done is later on, we demonstrated that by changes all of this, you look at the differences in tendogenic markers. And therefore, if you're looking into this, what we concluded in our simple in vitro experiment is, I want to go and make sure that my cells become well strained, I need to strain it to about 1 Hertz at 8%, okay? Or if I want it in large numbers, looking at what kind of outcome is actually to strain it up to 4%, which gives me a better outcome. However, tendogenic expression markers are better at 8%. So meaning to say that if you were to translate this towards some sort of tissue homeostasis, you may want to consider 1 Hertz as the way forward in improving tendon repair outcomes in most of your patients. Okay. Let me try this again. Okay, so this is another paper that we've published looking at how that behaves. I mentioned briefly on what it changed to topographical changes, but again, demonstrating the importance of how this exclusively strained at 8%, okay? And meaning to say that you literally need to stretch it to 8%. And this means if you're talking about, I do lots of hand surgery, is that if you're looking at having to go and repair for tensile forces for flexor tendon repair, you're talking about at least a minimum of 45 degrees change, okay, to allow 8% sort of strain in your tendons, okay. And later studies, we did demonstrate that the effect of calcium in our studies, and we do know that the signaling down molecule is definitely calcium dependent. So now that defeats the purpose for us to understand what happens if you're on calcium channel blocker, especially those patients on hypertension with this effect. our studies do indicate that nifedipine, for example, which is a well-known calcium channel blocker and very widely prescribed, has effect on the homeostasis of tendon, and therefore, in a number of conditions, for example, another one is the antibiotic, sort of like doxycycline, can result in tendon degeneration because it inhibits calcium. The next question is, can we manipulate by giving calcium supplements? This is something that we then look forward towards the prevention of tendon degeneration as a whole, especially when you talk about people with rotator cuff injuries, degeneration, or Achilles tendon degeneration. Maybe calcium will have a role in preventing further damage towards all this tissue. All right, we did look at the MSC regeneration, as I mentioned before, and as you can see in one of the studies that we put, the application of stretch-activated stem cells gave a huge amount of repair comparatively to that of areas of fibrotic changes. So you can see nice shining sort of tissue towards something that's very grotty and area for fibrosis. We even explored an idea of having to use mechanical impulse in trying to improve our cellular yield. As you can see, what we did was we put these dextran beads and we put them cells on board. So the idea is to put cells on those dextrose microbeads and subjected them to cyclical loading in a centrifugal force. And this centrifugal force results in two outcomes, which results in either the shear force from the forward streaming and centrifugal force towards the outside. What we showed that these forces increase the cell yield by over 100%, okay, 120 to be exact. And therefore, if you have problems in trying to explicitly looking for large number of cells, we would look into having to look at this sort of mini bioreactors as the way forward. So we are literally trying to manipulate mechanical impulses in cells in order to achieve our outcome as seen in this video. Other important outcomes, if you look at micro now, let's talk about micro bioreactors. And a few of my students, in fact, now looking at having to regulate not only the physical forces, but rather the hypoxic changes within the cells using pharmaceutical mechanisms rather than the pure bioreactors in regulating or improving the outcomes of cellular differentiation in our studies. These have downstream clinical effect. And in my experience, you're now talking about a different way of manipulating cells to bring the outcome better. Now, if you look into cell therapy per se, if I were to be able to manipulate cells, giving them better behavior, having them in large numbers, I can expect better outcomes in my cell therapies in years to come rather than your usual monolayer. So we've exposed this, we are exploring it, but in the near future, you will have a lot of outcomes. In our next models that we've developed into animals, we have shown that the outcomes of using a combination of these, like these physical forces and autocrine outcomes, have resulted in improved efficacy of up to 300%. And that's not a small feat. It's just that now we need to move it clinically, and first in human is a big pain. So hopefully in the near future, I think Dr. Nani is very clear on how regulatory works. The first in human is always a big issue. And if we're able to overcome that barrier, I think we will show huge amount of results that will change the way people perceive the use of merely growth factors, but rather the mechanical stimuli as the way forward. Right. So I'm just going to cover with one more exercise, the research outcome that we have. And just to let you know that what we've done is in the years is to look at our in vivo, because we look a lot of in vitro. And the idea for this is to look at whether exercise of medium impact has on cartilage. My area of research has been limited towards cartilage and tendon, although I've done quite a number of outcome studies, but rather my main interest is cartilage and tendon. And one of the things we subjected was to see whether or not medium impact isometric exercise can have an outcome on either old rats or young rats. So the idea is, what if somebody like me is subjected to exercise running with a gradient against somebody who's doing young? And it was interesting to see that after 8 weeks of training, whether high intensity, low intensity is a good outcome for any of these patients, especially in cartilage, right? We did tendon as well, but I'm just going to focus in cartilage for you for today because of the time sake. So we look into this group. So we train a sedentary group and look into the outcome. And what we found was the cartilage thickness actually changed in the trained group compared to the young. And therefore, we've looked into the old variant cartilage. The outcome in change of cartilage is actually improved up to 7.2%, whereas the young ones actually reduce initially, but later grow over time. We weren't sure whether this is the outcome that we really wanted to see. And what we did is we looked at whether or not there's changes on the different sides of the cartilage itself. While we did see that there is some sort of the density that has reduced in terms of cartilage number, but you can see that in the young, what we look into this is that the posterior condyle especially works in the trained group higher than that of the older part. So if I were to subject somebody old into exercise, you will find that they will be thinning in certain areas, but thickened with such areas, especially in those group with low outcome. Okay, so what we have here is in this picture here, the green outcome is all in the old patients, and let's compare the three group: week 1, week 2, and week 8. And W stands for exercise group, and S looks for sedentary. So those who are sedentary, especially old farts like me who sit down in chairs and chair meetings all day long, actually do well if I were to exercise. An improvement in cartilage in 8 weeks can be expected. If they're seen in rats, you can actually expect in humans as well. So the change in cartilage is well demarcated in a number of our histological studies, similar to one I presented just now. Except that if you are training later on, the cartilage do change, especially here. We've been training them for a certain number of period. You expect them to change. So therefore, those who are sedentary go and exercise now would benefit a huge more than those who've been exercising for the past 5 or 10 years. So I think that this is a good sign, okay, for all of us who don't really exercise a lot to actually go and start exercising, especially those in the middle ages like myself. All right. And again, we look into all these outcomes. And I'm going to move along in the interest of time so that you can ask questions if you're interested in some of these, is to look at the GAG protein, because histology is one thing, but you look into protein, and lo and behold, while the young has high amount of GAG, you notice that there's differences in the trained group over the weeks in terms of GAG. So the improvement is remarkable. So I think our preliminary results were very encouraging, and I think the outcome would actually be translatable towards human in later years. Okay, so I won't go into the next slides, but let's look into the clinical applications before I end my lecture. So in many instances for clinicians, you talk about the mechanotherapy as the way forward. But in next future, we may want to look at cell therapy in combination with mechanical forces, with sort of cell therapeutics, to understand that perhaps there are many ways how we can manipulate the natural history in just mechanical sort of stimuli. So progressive resistance training as the way forward here is something that has been adopted even without the basic science that I've embarked into. But what we can understand is that if you understand the cellular behavior, now we can actually put an adjuvant towards the whole outcome. And hopefully in the near future, okay, we can then understand, I think I've shown this image before, of how the translated from the body to the joint in a very deep manner and in combination may work towards our advantage at the end of the day. And mind you, for the audience understanding this, while I did go along with a lot of complex sort of stories and tried to make it as simple as possible, these are exciting times where you can now combine your knowledge of clinical applications and the combination of other adjuvant to result in the outcome that you want. Therefore, whilst most of us had out cell therapy, I've seen even Indonesia has embarked into stem cell transplant. You may want to consider other ways of manipulating, and one of the ways that you can simply do it from the very beginning is on mechanical loading. And based on the data that we have, it's no harm for you to now subject your patients towards specific mechanical loading that then translates to best clinical outcomes. So in summary, if you look into what we've looked into tissue engineering and stem cell research for my group, and mechanical signaling that talks about isolated stem cells cultured into all the way into human transplant, you understand that we can now use mechanical forces now in the in vitro section. We can then manipulate it during the process of harvesting the cells. We can then try to manipulate them during the in vitro period in the cells. We can then change the biomaterials to then manipulate it further to change, for example, nanofiber scaffolds in our transplant. We can then put the patients and subject them to mechanical loadings of different sorts, which you and I always known as physiotherapy, but specific physiotherapy that then targets on the defective sites of repair that can then result in the outcome that you and I really want. Okay, so I've going to come to the end of my slides, and basically I think the lecture that I've given has demonstrated without a doubt that the importance of tissue repair in musculoskeletal tissues, especially mechanical impulses. And therefore, whilst most of you talk about biomechanical relations in orthopedic research, one of the things that you may want to consider would be the mechanotransduction process, of which the cells themselves are leading towards the idea of cell perception is an important factor that needs to be considered. And if you're a researcher, I think that's the way forward in the near future. I would like to take a moment again to thank you, the organizers, for inviting me and giving me a chance to share an insights on mechanical impulse and biomechanical changes in tissue. And I hope it has been a fruitful day. I wish everybody here all the best and have a good day. Thank you very much.
Terima kasih kepada Prof. Tungku Kamaro atas pemaparan materinya. Mohon Prof. Tungku Kamaro kesediaannya untuk tetap berada di dalam ruang Zoom, karena setelah pemaparan Dr. Erika, kita akan melanjutkan pada sesi tanya-jawab. Apabila Bapak Ibu ada pertanyaan, dapat ditulis pada kolom chat yang nanti akan kita diskusikan pada saat sesi tanya-jawab. Selanjutnya, sebelum kita mendengarkan paparan kedua dari Dr. Erika Collins, mari kita lihat CV-nya terlebih dahulu. Dr. Erika Collins, Specialist Orthopedic, Consultant PhD, Personal Profile, Indonesian Board Certified Orthopedic Surgeon, specializing in shoulder and elbow service at St. Carlos Hospital, Pondok Indah Hospital, Bintaro Jaya, and Zuchi Hospital, teaching staff at the Faculty of Medicine, Universitas Trisakti. Kepada Dr. Erika Collins, kami persilahkan untuk paparan materinya.
Terima kasih Dr. Karina atas introduction-nya. Selamat pagi Bapak Ibu sekalian, salam sejahtera. Saya Dr. Erika yang pagi ini akan membawakan materi yang kedua. Untuk itu saya akan mencoba menampilkan slide saya. Apakah slide saya bisa dilihat dengan jelas Bapak Ibu? Bisa ya, okay. So please allow me to speak in English because we have a invited speaker from foreign country. My name is Erica. I'm an orthopedic surgeon specializing in shoulder and elbow surgery. So today I would like to bring a topic it's one of my favorite topic. I think it's natural because I'm a shoulder and elbow surgeon. It will be in line with the previous talk by Prof. Kamaro because he is a hand surgeon. So mostly people are dealing with quite similar things in the upper extremity surgery. My topic is about the role of biologic method in enhancing rotator cuff repair. So let's get started. Today, the outline of the talk is rotator cuff tear and overview for those who are not familiar with. So I will try to introduce the challenges in rotator cuff healing, And I would like to try to introduce and let you know about how we define a failure in rotator cuff surgery and what's the options for healing enhancement from bench to back. The rotator cuff tears, an overview. This is a very common thing to see in orthopedic clinic. So it's a day-to-day basis when you run an orthopedic clinic, private or government. So as a shoulder surgeon, 70% of my clinic is these kind of patients. Approximately, we can see from the states that we have 98 patients per 100,000 individuals will have the surgery annually because of the tears. It is accounted for 1,360 cases over 100,000 orthopedic patients per year. So it's about 10% of the orthopedic procedure in total. So the goal of the surgery is to eliminate pain, of course. People are coming to see the doctor actually mostly because of the pain they have from the tear. And we would like to try to restore the shoulder function. So as everybody knows, there are three most common ways to do the surgery for rotator cuff tear. The first is the traditional open. The second one is the mini open. It's like a transition between an open procedure to an arthroscopic as a minimal invasive one. And then now it is more common to see arthroscopic procedure to treat rotator cuff tear, although open surgery is still commonly performed in some region. So what are the challenges in rotator cuff surgery? So unfortunately, there is a very classic paper in orthopedic surgery, Lisa Gallups. She defined that if you have a massive or large tear, you might have a 94% of failure. So this is a very sad news for orthopedic surgeons. And there is a fact that although patients experience positive clinical outcome following rotator cuff repair, the mechanical failure, we can still see the mechanical failure, and it is still becoming a significant concern. So this is the quote from the paper. Despite the pain resolution and improved subjective outcomes, we can see a high rates of incomplete healing, or re-tearing. So we don't know whether the tissue that we have repaired from the supraspinatus to the greater tuberosity is healed at the first time, or it healed and then it re-tear. So how to define a rotator cuff repair failure? So we have two kinds of failure. The first one is the clinical failure. A clinical failure, you should usually can check with the patient whether the pain is improving or still persistent. The second one, you would like to assess the shoulder function, whether the range of motion is okay, or there is a decrease in muscle strength in the affected shoulder. These are very easy to assess in a clinical practice. The second failure is a mechanical failure. These can be defined as a loss of fixation or repair. There is a failure to heal or repair. There is a paradox in rotator cuff surgery known as structural integrity doesn't always correlate with clinical outcome. So if you have a tear after rotator cuff repair, it doesn't always look bad clinically. So it's a paradox. Studies from the giants of orthopedic surgeon, mostly shoulder surgeon, like Joseph Iannotti, Pascal Boulou from France, and Collins, have shows the importance of rotator cuff integrity. Joseph Iannotti has shown that patients with an intact repair had 92% abduction strength compared to those with repair, 75%. Pascal Boulou showed that a healed rotator cuff is associated with a higher constant score, constant score is a functional score for shoulder, and the shoulder elevation is better if you have a heel rotator cuff repair. Collins showed that shoulder strength correlated with the repair integrity. So surgeons always try to aim beyond symptoms improvement. We focus on maximizing the strength because you want to have a very strong shoulder to continue activity daily living and function through the structural integrity. So a quick discussion here. In a shoulder conference, we always argue, do we really need to repair it like a watertight and ensure there is no retear? Even a small retear means nothing sometimes in the patient's life. So if you can achieve a full healing of rotator cuff, you will give a higher chance for the patient to recover for both strength and function. Okay, next business is to talk about the timing of rotator cuff repair failure. How do we know that our surgery is successful or not? So it is very important to serially or sequentially examine your patient. So in the follow-up visit, you might want to check the outcome, the shoulder function of your patients. So the second tips is to have a sequential imaging studies that may shed light to the retear. So mostly I will have the MRI examination for those patients who complain of a new pain after the surgery. Those patients are maybe a high-risk patient to have a rotator cuff repair failure. So according to these 3 studies, majority of rotator cuff repair is within the first 3 months. So this is very important to follow your patients very closely and narrowly in the 3 months after the surgery. While they also describe that delayed healing can take to 6 to 12 months, so be patient. Addressing timing challenges. So surgeon would like to try as far as possible to prolong the tendon attachment to the tuberosity, the greater tuberosity. These are usually achieved by enhancing the repair strength, speeding up the tendon healing before the failure occurs. So there are 2 causes of a repair failure. So the first one is the weak link. Where is the weakest link of the rotator cuff repair? So study has shown that the weakest link is the suture tendon interface. I will show our study to prove this concept. So the second one is the rotator cuff patient are usually a degenerated tendon patient. So these are very old patient or geriatric patient with a poor tissue quality. So this kind of patient, their tendon cannot resist the suture pull, so they have a lower suture retention. So mechanical augmentation was always try to be achieved by surgeon in order to strengthen the rotator cuff repair at the time 0. When we look at the efforts by the surgeons to provide mechanical augmentation, we have tried many anchor type like metal or soft suture anchor or PEEK. We have tried suture material, the knot type, the stitch configuration, the size, shape of a tissue and penetrating instrument, and the size of the tissue bite. So from every studies out there, it is already proven that only one factor is actually contribute to the mechanical augmentation, which is the stitch configurations. So enhancing the biologic healing of rotator cuff repair, let's get to the bench. So the left side of the picture is actually a native bone tendon interface. Maybe for those friends who work on the basic science part, this is very common. You can see there is a very nice transition from the tendon, the fibrocartilage, the tide mark, the dashed red line, and the mineralized fibrocartilage and the bone. So these are the goal for the surgeon to recreate. Unfortunately, after a chronic tear, the native bone tendon interface are gone. So these are our studies in, I think in 2019. So we look at the suture material, I'm sorry, not the suture material, the side or the position of the suture knot if you're doing a rotator cuff repair. So these are from a Sprague Dolly rat. So if you put a knot on top of the tendon, which is easier, so the knot of the tendon will delay the repair healing. So if you put the knot on the bone, so the repair healing phase is superior from this knot on the tissue. Why? Because the knot on the tissue will cause a stress concentrations and tendon strangulation. The tendon is a vascular structure, and then you put a very strong knot on top of the tendon. So it will definitely break down and cause a local tendon necrosis. And that's why this is the weakest link of the rotator cuff repair configuration. Furthermore, sometimes the knot can cause a chronic inflammation, and these can have a risk of retear. Okay, what can we do as a surgeon in the clinical side? So this is more of a clinical side of the practice. The first and the oldest technique is to do a microfracture. So you make a small hole in the bone to allow good cells, good juicy cells like bone marrow elements, mesenchymal stem cell, and growth factor to surface on the top of your repair. So it will cover your repair like a blanket. That's why we call it crimson duvet. So this method is introduced by Stephen Snyder, another giant of shoulder surgery. So after you put a microfracture and you decrease the pressure from your shoulder joint while you're doing arthroscopy, you can see a blood coming up from the hole that you make. So these are the hope that the stem cells and the good juicy stuff like all the growth factors you can name can enhance your healing, repair. What are the outcomes of microfractures? So good news is quite consistent. So quite consistent in terms of enhancing healing for a large to massive tears. But it is not very significant or similar if you are doing that for a small to medium size. So these are one of my studies. We look at the microfracture in the rotator cuff tear models in the rat in 2020 in American Journal of Sports Medicine. So oftentimes we ask ourselves in surgery, do we have to poke a big hole and then we hope that the blood is coming more and more rather than to poke in a small hole? We do a study on a mouse that we compare two kind of size of microfracture. A small one is 0.5 millimeter. The big one is more than 1 millimeter. So the big microfracture actually is a danger to your tuberosity, to your bone, because it can cause a non-union. As you can see in the micro CT here in the right corner of the screen, there is a hole in the greater tuberosity of the mouse when you do microfracture with a larger diameter. And talking about the quality of the greater tuberosity, we also did another study, maybe a bit far from our topic today. If we strengthen our bone, the greater tuberosity in this case, by combination of raloxifene and vitamin D, it can actually prevent a local decrease of bone mineral density at the greater tuberosity. So we hope that it can enhance bone to tendon healing. So in this study, we use 3 group of mouse. So the first one is, of course, the control. We didn't do anything to the mouse. Second one is the mouse with induced osteoporosis, and we do a ovarectomy. And the third mouse is we induce them to be porotic. And the mouse, the first one, we didn't give anything. And the second group, we give a raloxifene and vitamin D and check the rotator cuff healing after we perform the rotator cuff repair surgery. Second one, I'm not sure in Malaysia, but PRP is very popular in Indonesia. People like this kind of stuff, and it is very well known at least in dermatology. So in orthopedic surgery, it is getting more and more popular. So what is PRP actually? PRP actually, you take your own blood and you make a concentrate of the blood that you take from a peripheral blood. So the hope is you get the very concentrated part of the blood which contain a lot of healing cells. So there are 3 premises that they promise us in rotator cuff repair. First, it can enhance the proliferation of the tenocytes. Second one, to promote synthesis of the extracellular matrix and promote angiogenesis. So what are the challenges in PRP studies? The problem is every study in orthopedic surgery, at least in rotator cuff surgery, there is a high variability in PRP concentration, content, preparation, and delivery methods. And there is a high variability about the platelet concentration throughout the day. So you inject in the morning, what happened in the night, and the next day, we don't know. And the activation cascade of the platelet to create a gel, or you use a clot, a number of white blood cells that might affect the healing potential, and its inconsistency in findings. These are heterogeneity in studies that reported in shoulder rotator cuff repair surgery augmented by PRP. So the outcomes mostly, there are so many studies I can't even mention in the rotator cuff repair augmented with PRP. It shows that it will improve, it improves structural integrity. It improves, especially in small and medium tears, and therefore it can improve pain and functional score. The third one is maybe the champion for now. So the MSC, the mesenchymal stem cells. For rotator cuff repair, usually there are 2 donors for MSC, the adipose-derived stem cell and the BMC, bone marrow concentrates. So the bone marrow concentrates is very rich of stem cells and growth factors. I think you already learned from Professor Kamarul's slides before. So I'm not going to have a redundant talk at this moment. Mesenchymal stem cells is a very potential adjunct. So it's an adjunct, not the main ingredients or factor in rotator cuff repair. However, same as like a PRP studies, there are many variability in progenitor cell concentration. So how many cells per milliliter and the preparation method, these can impact the outcome. The next one is quite popular in shoulder surgery. So biologic scaffolding graft. So you have a scaffold that have a biologic function or profile. So it has a double function. It can provide biologic healing and it can provide mechanical or protective support. This has been a very holy grail in orthopedic rotator cuff surgery. So we both like to see our repair is strong, but also have good cells. So biologic graft, according to the source and in the medical textbook, very cliche, we know that we have a xenograft, which is from other species, allograft, and autografts. So xenografts, unfortunately, that we have a bad report, many local reaction inflammation, we have to take out the graft. But allo and autograft seems to have a very consistent report of being a positive report. Function, we can have a graft as an interposition or bridging, or we can have the graft to augment our repair or overlay. Let me describe this later. These are the function of the graft. When we have an interposition or bridge, the upper part of the top figure, it means that you stitch the graft in one side to the supraspinatus tendon and the other you dock to the greater tuberosity. The other function of the biologic graft is to augment your repair. You do the repair first and you put the graft on top of repair as an airbag or a seat belt. So let's talk about the adipose derived of, okay. I should talk about this beforehand, but let me explain. So the adipose-derived stem cell, we have at least these two research study are quite long time ago, but the result is quite valid. The Kim et al. Studies 35 patients underwent a rotator cuff repair with a 1 year of follow-up. The repair is low, 14.3% compared to those without MSC, 28.5%. But the outcome is similar. The other study is from small animal model from a massive rotator cuff tear. It can reduce muscle atrophy, like Professor Cameron slides before, and can regenerate fibroadipogenic degenerations. But it is very hard to prove in a human model, because we don't know how to actually see the regeneration very well. Mostly, we can't really see the regenerations. Let me share a study of mine about the adipose-derived stem cells. We try to create a chronic rotator cuff tear in a mice model. So these are the mice model. We put engineer cell sheets. So in these cell sheets, we try to immerse the adipose-derived stem cells and maintain the cells into the sheets, and using a fibronectin, a protein. So we deliver the cells into the repair sites, and the repair sites should maintain the seeds for a period of time. So the problem of stem cells in rotator cuff repair is, once we inject the stem cells into the repair and we run the water in the arthroscopic surgery, of course we use a water, it can wash out the cells. Sometimes people use a clot or another collagen to maintain the cells in the repair sites. So bone marrow concentrate, there are two prominent studies about this. Philip Hernigo, he showed that arthroscopic single row patients with stem cells injection versus none is superior with the stem cell injection. Gomez et al. Also showed that the bone marrow concentrate injection to the mini open rotator cuff repair resulted in favorable outcome. Okay, coming back to the graph. I apologize for the weird arrangement. Porcine membrane allograft. So at the beginning, we have a lot of porcine membrane allograft as a patch, but studies have shown that there are inconsistency results that cause a local inflammation reaction and early graft failure. That's why we don't like to use this graft anymore. Second is the bovine collagen implant. So the role of this implant is to thicken the cuff. So if we have a partial repair, this is a very good choice. But this is only available in the States and some European countries due to regulations. So this kind of collagen implant is an overlay. So we don't actually get a mechanical support from this implant. ADM, or acellular dermal allograft. So basically these are tissue from our cells. We wash it and remove the donor cells. So it only leaves us with the extracellular matrix, ECM, collagen type 1. We want this collagen because we want to protect our repair. We want to increase the load of Vela. The use of ADM is actually very well known, and it has been commercially disseminated very well all over the world, I think. So it can optimize the environment for host cells and growth factors to promote repair side of the healing. The outcome of the dermal graft is it can support repair side by increasing strength and load to valor with the augmentation. The clinical studies demonstrate improved structural integrity and lower recurrence rates in the ADM augmented rotator cuff repairs. So another technique I can introduce is from our study. So in arthroscopy 2020, we try to mimic the concept from the knee, the remnant preservation ACL surgery, which is very well known. So we try to use what God has give us, our own tendon. So if you have a tear in rotator cuff, like the right picture, you should usually have a small remnant. Maybe not, maybe yes. But if you have a small remnant in the greater tuberosity, you will want to use the remnant to enhance your healing. Because we show in our study that remnant preservation repair will result in better healing because it has a native bone tendon interface. So this left picture are remnant removal surgery. So as you can see, from 4 weeks to 12 weeks, there is no regeneration to the native bone tendon interface. There is no fibrocartilage, mineralized fibrocartilage, and it's all not arranged very well. So in the remnant preservation surgery, you can see the native bone tendon interface very well. So it can heal superiorly compared to the remnant removal surgery. Next one is the subacromial bursal preservation. So what is a bursa? I would like to remind you, bursa is some soft tissue on top of our rotator cuff, and actually this is something that we remove during surgery. Unfortunately, why? Because we need a visual. In a keyhole surgery, visuality is everything. So you tend to remove the bursa as much as possible to gain a good view. So a bitter fact that rotator cuff tendon is avascular. It has become an issue in rotator cuff healing. So bursa is very rich of vascular cells and stromal cells that may contribute positively to the rotator cuff healing. So we did a study that published in the Journal of Shoulder and Elbow Surgery 2020 to compare the subacromial bursa preservation surgery compared to bursa removal. And it showed that in a bursa removal, the top picture, the collagen tissue arrangement is very not parallel. It's messed up. In the bursa preservation surgery, the collagen are aligned in manner and parallel, and this has shown a better score than the bursa removal surgery. So last but not least, these are my last slide of the topic. So the biologic augmentation in rotator cuff repair, you should use the strategy, I think, which is consistent to the reported result. So although there are many ways or many studies that shows positive result, you should use only the consistent one. So at least now, if we translate from bench to bed, the biologic augmentation shows good result from the augmentation by ADM, as far as I know. Other studies topics are quite dynamic. It's still developing, and I hope to see a great result from the researchers from the bench sites. I really would like to thank the organizing committee, the Dr. Nani and Dr. Karina as the CME of our university, our dean, vice dean, and official bearers of the university, and foremost our invited speakers, Professor Kamarul, which has already gave a great lecture for everybody here today in a very good morning. I wish you well, and I return the stage to Dr. Karina.
Ya, terima kasih Dr. Erika atas pemaparannya. Selanjutnya kita akan masuk ke dalam sesi tanya jawab. Untuk yang pertama, kita buka untuk Prof. Tengku Kamarul. Pertanyaan dari Dr. Dr. Rini Mustika. The question is this the biomechanical technique can be used to prevent degeneration of tissue in elderly, or it only repairs the damage that already happened? And if it can help prevent, how and when to start the program to prevent it? Thank you.
Okay, thank you. Terima kasih banyak di atas persoalan tu. I'm very happy you came up with that question. Maybe I didn't make it clear. Mechanical stimuli is not just for repair, it's actually meant for prevention. So in a study that we've done in looking into people and the cohort, and we look at the number of cases, because Netherlands has the largest number of population disease sampling. And they have a cohort of population sampling that they cross over for the next 20 years. So the development as you age, then develop things like rotator cuff test and all that. So what we can summarize, I won't go into details of the research, is that macam tadi Erika menceritakan pasal rotator cuff degeneration. Now, the main disease in rotator cuff tear are usually because of tendon degeneration rather than traumatic injuries. So tendon degeneration occurs for all the people like myself and whatnot. When you hit the age of 45 and above, you'll find that there will be shoulder pain. Okay, of course, some shoulder pain is attributed towards your cardiac status, but in this case, most shoulder pain is attributed to you punya to the damaged tendon. And what we found is because people tend to not load. Okay, if you think about it, right, when we did our number of studies, how many times a day do you remember that you have your overhead punya activity, means your hands reach up to get something on the shelf? In our survey, we did over about 1,000 people. It's actually less than 10 times per day. Okay, most people will only lift up their head maybe twice or 3 times a day. So meaning to say that most times kita punya shoulder, we only lift it up to a maximum of about 40, 45 degrees, maybe 60 to this extent, but we never go beyond 90 degrees or above his shoulder. And even women naturally only do a lot of things is actually just at the shoulder level. So because of that, the tendon of the rotator cuff undergo disuse atrophy to a certain extent, and all you require is that you benda tu dah nipis ya, dah degenerate. All you do is, if tiba-tiba angkat handbag ke ataupun shopping bag yang berat ke atau terlanggar sikit, you can have tendon ruptures. And sometimes it doesn't happen, no. Tidur malam bangun dah rupture. Okay, and honestly, you could have prevented that from happening if we actually have exercises loading specifically on all these tendons. And one of the things, there's a project led a large population dekat Liverpool by this ni apa nama saya lupa, the physiotherapist, and that was a long time ago, was to rehab to teach people that at least for a certain day at a time, make sure that you exercise pakai simple things like bucket and all that to strengthen you punya rotator cuff tendon to prevent from shoulder pain. And dalam dia punya study, I remember she was explaining to me one of the studies that they said that the number of people who recovered from rotator cuff that doesn't require surgery can go up to 90-95%. So meaning to say that if you do exercises to prevent this thing to happen, then you may be one of the people who will likely to benefit from mechanical loading prevention of degenerative changes. Okay, similarly, it's more difficult for me to prove for cartilage, nevertheless, but that's what the animal model that we're trying to do. So to your question in a very simple answer is that yes, mechanical loading helps to prevent tissue disease or tissue damage, but it also repairs. So yes, I think this is worthwhile investigating. Thank you.
Okay, question number 2, Prof. From Nurizati. Good morning, Prof. Thank you for the interesting talk. I have a question regarding tensegrity structure in human body. How does stiffness of tensegrity structure in human body change? Thank you.
Thank you for the concept, for the question. The concept of tensegrity is actually based on the value that I talk about cells. Okay, if you talk about tensegrity as a whole for the human body structure, then you talk about muscle. Okay, for example, when I sit up here, there's something making sure that I don't end up like orang Malaysia kata seperti sotong. Try tak boleh diri, dia tak ada tulang belakang, dia akan jatuh ke depan. So what's holding us in our position is because of the balance of the muscle. All right. So if you're talking about the whole human body as a form, tensegrity optimus outcome is the fact that kita ada muscular punya structure. And honestly, while a lot of physiotherapists and rehabilitative physicians talk about having to improve core muscle, they're actually improving the tensegrity of a whole human subject. The concept of tensegrity I gave just now was based on each cell, tiap cell, because of the microfilament, not for the whole human being. But if you're talking to apply to a whole human being, then you're talking about muscle. So therefore, if you're asking me what is it like, the simplest form would be muscular lah, you punya structure. And kalau you nak start with that, is actually core muscular punya strengthening. So how you strengthen, of course, dia ada banyak cara. There are isometric, isokinetic, localized, focal, general, all that thing. I'm not the expert in this areas, tapi memang each one will result in better tensegrity of the muscle itself. Please remember, kalau you punya you notable kan, kalau for example kalau somebody with ACL deficiency, kalau dia punya tu is mild to moderate, ni Erica can also help me there. One of the easiest way kalau kita tak nak surgery is to do muscular strengthening, alright? And one of the exercise yang kita ada is squats exercises. And the idea is to stabilize the knee, all right? And the similar process you talk about tensegrity is to hold the knee in such a way that it gives a sort of mechanical balance of realignment. And not only that, to a certain extent, strengthening you punya ACL along the process. Please remember, most people think that ACL, the anterior cruciate ligament, is a static thing. It's like one tissue that will never grow, never improve, never heal. But that's not really true though. All tissues have a potential to heal, except the potential can be very low. Similarly, it goes to cartilage. Orang kata cartilage doesn't heal. It's true that cartilage does not intrinsically heal on its own, but it has the capacity given the right environment. So similarly, what I'm saying is you're talking about the concept of tensegrity of the whole human being. You're talking about muscular strengthening. Okay, thank you.
Thank you, Professor Teguh Kamarul. And next, the question is for Dr. Erica. First, from Dr. Yesi Arsuria, is there a difference between RCR failure in adults, the elderly, and children? And what is the most effective way to avoid RCR failure? Thank you, Dr. Erica.
Okay, I'll share the stage with the moderator. Dr. Yesi, thank you for your question. Actually, it's very hard for me to answer this because rotator cuff tear, it's very, very unlikely to happen in children, very unlikely. So even I haven't seen one in the children. From the adult and geriatric elderly, it is very common, at least in the elderly part. So the difference in the rotator cuff repair valor is a bit different. In the elderly population, it's usually the degenerated tendon cannot withstand the suture because the tendon is degenerated, as Professor Kamarul already said before. But in an acute tear in a younger population, let's say here you state an adult, the tendon is strong, but they have an accident, like a sports injury. So the tendon is in good quality. So the failure is usually from the re-injured. So if you fall again or your fixation is unfortunately not quite good enough at the time zero, you will have this kind of failure. So failure is mostly mechanical for adult, but failure in elderly is mostly biological. Thank you.
Okay, the next question is from Dr. Sujitno Fadli to Dr. Erika. For rotator cuff surgery for elderly, how significant using additional stem cell for the improving the recovery and also using PRP? Thank you.
Thank you, Dr. Sujitno. The stem cell use for rotator cuff repair. So there are many studies out there to show the role of the stem cells augmentation in rotator cuff repair. But as I said before, there is a high variability on how they deliver the stem cell into the repair and the type of the cells. These are two major confounding bias, I think, if you look at the literature, if you review the literature carefully. So unfortunately, the answer is quite not favorable for you too. So if you ask me for a recommendation or best evidence, I think the evidence is not good, not quite settled. I cannot recommend stem cell as the first line for my patient because you have to have a very solid evidence to recommend this to the patient. And there is no RCT yet to help us, to guide us to recommend a stem cell as an augmentation for your rotator cuff repair. Thank you.
Okay, thank you. Maybe Prof. Tengku Kamarul, this is the question from Siska. Good morning, Prof. My question is, what's biologic mechanism in people with hypotonic muscle or low tone muscles? Is it regarding with protein mutation or not? Thank you.
Sorry, last bit apa? Is it apa tadi?
Is it regarding with protein mutation or not?
Protein mutation, sorry.
Yes, protein mutation or not.
Protein mutation. Okay. Now, the question needs to be a bit more specific. You cakap dengan saya tadi is hypotonic muscle. Now, if you're talking about hypotonia, there are many outcomes, whether it's genetic outcomes, whether it's actually environmental. Okay, kalau if you talk about genetics, obviously it's protein related lah. There's nothing much you can do. And the only way that you can do this is correct the underlying problem, which is genetic punya manipulation. Which again is not really being proven anyway. It's not being successful as yet. I mean, there are trials, but belum successful. Obviously, while waiting for that, you can then give protein punya supplements, ataupun you can even give parenteral ataupun oral depending on what kind of proteins you're deficient lah. Because most proteins cannot be absorbed to oral, so most of them is actually through parenteral. So if you're asking pasal hypotonic due to environmental conditions, those are not directly linked towards protein protein metabolism, but rather because of the protein production. That can easily be manipulated, but again, protein development and muscular outcome, etc., is not simply just mechanical stimulation. Yeah, please remember that it also has to do with nutritional values, the content, as well as other environmental factors, macam for example, stimulation of radiation, stimulant of other bits, for example, metabolism or cellular transformation, etc. So that's why I say your question needs to be very clearly defined what you want to answer, because it can go on and have the argument. But I'm just addressing to your question, which talks about environmental costs for hypotonic conditions in muscular problems. And as my answer goes, in that condition, mechanical does help, and protein does get involved, but not the way that you think as malnourishment, but rather the poor protein production because of various factors. Okay, I hope that helps to answer for now. Thank you.
Okay, can we have a last question, Prof?
Oh, sure. Boleh.
Okay. From Amira Zulkifli. Good morning, Prof. Thank you for your insightful talk. My question is, in research, how do we replicate the intricate musculoskeletal biomechanical condition to reproduce the biomechanical environment as closely as possible in our experimental models?
Okay, now your this question is very interesting, because all I've shown you is actually in vitro, in vivo. Now, in my, I've not given this lecture for a very long time. It's talking about translating research finding to clinical application or bench to bedside. We tend to look into the both of side between bench and bedside as two separate things, but actually they're very closely mimic. What many students or many younger scientists tend to expect is that if I were to do research in vitro, this can easily be applied in vivo. It doesn't happen that way. All right. And therefore, when you translate findings, you must make sure that the process of translation move in a very important sequential manner. So while I did tell you about 1 Hertz, 1 Hertz is one full rotation, or one full frequency or 1 full per second. Meaning, imagine kan, kalau I ask you to go there in humans kan, untuk gerak, for example, jari lah, okay? It's 1 second. This is 1 second. So imagine you subject your patient to doing that for 1 second. It's not translatable that way. And what you need to really translate later on is how you need to have the interim in vivo model, where you now translate your findings into in vivo. So a bridge, what we call as preclinical studies, is rather important for you to translate. You cannot simply just take the data and do that. What we know in vitro may work in vivo, but it has to be translated clearly. Now, the next question is, how do you translate? This is where the complexity begins. The first question is, apa nak translate-nya? Adakah you're talking about protein? Are you talking about cell numbers? In cell transplantation, are you talking about mechanical stimuli like the one that I mentioned just now? So all of this needs to be adapted in a more closely mimical environment, and you try to translate that based on whatever evidence you can get, and try to look whether or not it validates towards an in vivo model. So please, for all the younger scientists out there, jangan rasa yang saya sudah buat benda ni dalam laboratory terus boleh masuk ke manusia, because there's always a phase of change and that takes time. So I hope that answers the question on how you translate. So jangan orang kata nanti 1 Hertz saya akan buat patient 1 Hertz, jari dia sampai tercabut-cabut digerakkan. Okay, so don't do that. Okay, thank you. All right.
Okay, thank you, Prof. Dan pada akhir acara, kami akan mengumumkan untuk sesi pertanyaan terbaik, yaitu pertanyaan pertama yang diberikan oleh Dr. Rini Mustika. Is the biomechanical technique can be used to prevent degeneration of tissue in elderly, or it only repairs the damage that already happened? And if it can help prevent, how and when to start the program to prevent it? Untuk pertanyaan kedua terbaik, yaitu dari pertanyaan Dr. Sujitno Fadli. For rotator cuff surgery for elderly, how significant using additional stem cell for the improving the recovery and also using PRP. Selamat kepada dua peserta penanya terbaik untuk nantinya dapat diklaim hadiahnya. Baik, pada puncak akhir acara, kami dari tim Continuing Medical Education mengucapkan terima kasih sebanyak-banyaknya kepada Prof. Tungku Kamarul dan juga kepada Dr. Arika Collins, spesialis ortopedi. Terima kasih kepada seluruh peserta, Bapak Ibu. Terima kasih atas partisipasinya. Sampai jumpa kembali di acara Continuing Medical Education Fakultas Kedokteran Universitas Trisakti bekerja sama dengan Doctor to Doctor. Selamat pagi.
Selamat datang di FK Trisakti, tempat kita berjuang menggapai mimpi, jatuh bangun tetap berdiri kembali, kan ku kejar mimpi ini. Sivitas FK Trisakti tercinta, sahabat keluarga dan rumah kita, ciptakan karya dalam sinergi, bersama taklukkan hari. Kadang lelah ingin menyerah, sejenak istirahat tak mengapa, kemudian lalui, jangan berhenti. Dalam doa pastikan terlewati. Selamat datang di FK Trisakti, tempat kita berjuang menggapai mimpi, jatuh bangun tetap berdiri kembali, gapai mimpi mulia ini. Semua perjuangan untuk masa depan bersama FK Trisakti.
Halo rekan sejawat, berikut adalah cara akses sertifikat pada webinar ini. Klik pada button Get Postage pada akhir acara. Silakan isi postage yang tersedia. Jika sudah selesai, silakan klik pada button Submit. Jika lolos, silakan klik button Get Certificate serta masukkan nama dan gelar. Bila sertifikat belum siap untuk didistribusikan, silakan cek secara berkala pada button Certificate di bawah video webinar. Terima kasih.